Awesome. Can you see it now?
Yeah, perfect.
Okay, fantastic. All right, I am Dr. Doreen Mensah. It's my pleasure to be with you guys today, and I'm going to be talking about upper respiratory tract infections. So the learning objectives is to review the anatomy of the upper respiratory tract, talk about infections of upper respiratory tract, the diagnosis and treatment of these infections, and complications relating to infections of the upper respiratory tract. So let's start off with the anatomy so that we all know like where we're from. So upper respiratory tract consists of the mouth, the nasal cavity, down the pharynx, all the way to the true vocal cord. So from here, all the way to this line, that is the extent of the upper respiratory tract. So when you think about the infections of the upper respiratory tract, that's what we are talking about. And the upper respiratory tract infections are the common cold, pharyngitis, rhinosinusitis, and laryngitis. Let's start with a case. So I'll read the first case. You guys can respond, and then we'll see what the answers are. Okay. I want to do this way. Can I do this? Okay. So at 26, can you see me?
Yeah. Let me know if you want me to have someone read the question or if you want to go.
Yeah, can we get someone to read it? That would be great.
Anyone volunteer? Oh, I see Raj unmuted himself.
Yeah. Any volunteers? So I'm gonna start. I'll pick random people. Oh, Joseph, I know you. Joseph Menard, I know you from clinic. Please read for me. Thank you so much for participating.
A 26-year-old woman comes to clinic complaining of a bad cold. She woke up 3 days ago with sore throat and rhinorrhea. She complains of fatigue and her nose is sore from frequent blowing. She has a headache. She states that after 2 days of symptoms, phlegm turned from clear to yellow-green. The most likely cause of her infection is A, influenza, B, rhinovirus, C, adenovirus, D, respiratory syncytial virus.
So take a few seconds for you guys to answer.
It's anonymous, guys, so you can.
It's anonymous, so we just want to know to, just for learning purposes only. Are we good?
So we have 66, 69%, 70 people, 70% of the people already replied. So okay. I can share.
Yes.
The results. So these are the results. So most of the people said B.
You guys are right. Exactly. The most likely, so I need to close this screen. So the answer is the most likely cause of infections with a common cold is rhinovirus. Oh, it's not letting me advance. Oh, there we go. Okay. So common cold, AKI, mild upper respiratory tract infection, from 3 to 10 days, is all viral. Over 200 different subtype of viruses that are responsible. The most common being rhinovirus, which consists of up to 50% of the infections that cause the common cold, followed by coronavirus that make 15%, then influenza, and then you have a smattering of RSV, adenovirus, which normally you would see like an outbreak situation, like the military and schools, daycares, like that. It is by far the most frequent acute illness in the US and in other industrialized countries. I'll go back for a second. And it has a huge financial burden in terms of lost productivity. Annually, this is about 26 million days lost from school, 23 million days lost from work because of people being sick with the cold. There are seasonal variations of some of them. For example, rhinos normally in the fall and spring, and coronavirus you see mainly in winter, spring, and adeno happens whenever it feels like it. see variation. Transmission of respiratory viruses, the hands. So direct contact with an infected person or indirect with a contaminated surface. Then there's small particle, such as like aerosol, like from sneezing and coughing, large particles from being in close contact with somebody else who's infected. Cold viruses can live on the skin for up to 2 hours. Rhinovirus can contaminated surface can last for hours. Of note, using a tissue or a handkerchief, like a cloth handkerchief or napkin, as you guys will call it, is great because the viruses don't survive in that type of material, those type of porous material. More than 90% of patients with cold viruses, you cannot detect it in the saliva. So these adorable little three, these are my nieces and nephew. These two are twins, they're about 7 months. And then this guy over here with the messy face is 2.5. Risk factors for cold viruses are children, exposure to children here in the homes, psychological stress, not sleeping enough. So people who get like 4 hours, 5 hours of sleep, that is not enough. And that increases your risk of getting sick. People who have pre-existing sleep disturbances, and moderate physical exercise decrease your risk. So if you want to decrease your risk, exercise and sleep more. Symptoms of common cold. It is because of the immune response to the virus, as opposed to the viral damage to tissues and the anatomy that I showed you before. And so the symptoms, as you guys know, nasal congestion, discharge, sneezing, headache, fever, conjunctivitis. And the symptoms last, again, up to 10 days. However, in 25% of the cases, it can last for more than 2 weeks. On what are we focusing on? General appearance, vitals, HDNT, and lung exam. And what are we looking for? Conjunctival, and what we might see rather is conjunctival injection, mucosal swelling, pharyngeal erythema. Hardly ever would you see any adenopathy just from, and most of the time the lungs are clear, unless there's bronchospasm due to the upper respiratory infection. You might hear some wheezing or something like that, but generally it's clear. Diagnosis, what else can look like a common cold? People who have seasonal allergies, people who are allergic to substances. Bacterial pharyngitis can look similar. Tonsillitis can look similar. Acute bacterial rhinosinusitis. Influenza, think of influenza if there's high fever, headache, malaise. Think of pertussis if you have this prolonged cough with a paroxysmal prolonged cough with vomiting plus or minus apneic episode. Remember that patients who have been immunized, with Tdap might have a slightly different presentation than this. There's been a resurgence of pertussis. So if the person is more than 10 years past their vaccine, they should get revaccinated. Complications of the common cold. Most common is acute rhinosinusitis, mainly viral versus bacterial. Asthma exacerbation. 40% of people who get upper respiratory tract can get an asthma exacerbation, and the culprit most of the time is rhinovirus. You can have the extension to the lower lung, right? So the lower tract, I should say, the lower tract, which would be the bronchitis, bronchiolitis, pneumonia, as in the situation with RSV, which can cause both upper and lower infections, right? Influenza can do the same thing. You can also have extension into the ears, causing otitis media, because the viruses cause a eustachian tube dysfunction and affect the pressure regulation and proper clearance in the middle ear, setting people up for middle ear infections. Treatment. It's viral, so no antibiotics. Your patients will be begging you for antibiotics. Not necessary. not supposed to do anything for them. So aim for supportive care, analgesia, like your NSAIDs and Tylenol, and something for decongestion. So the antihistamine and the combination of antihistamine and decongestion seems to be more effective than just one alone. First generation antihistamines like Benadryl work really well for the rhinorrhea and sneezing. Intranasal cromolyn is really good for the rhinorrhea, sore throat, and coughing. So they want something, that's something you can give them, that would be quite helpful. You can also use intranasal ipratropium for similar symptoms. And there have been systematic reviews that have shown that people using the cromolyn recovered faster than the placebo group. Third piece that have marginal or probably no benefit. First, dextromethorphan. And dextromethorphan, you guys should pay close attention to this because it is in a lot of cough suppressants. So when you look at Buckley's, you look at Robitussin DM, the DM is the dextromethorphan in there. Destim, a lot of them, the active ingredient to suppress cough is dextromethorphan. It is quite similar in nature to codeine, and it works on the sigma opiate receptor in the medulla, in the brain, to suppress cough. Good for that component, however, is an agent that is frequently abused by teen and young people from 12 to about 5. They get a high from it because it's an opiate, right? They get a high from it, and people end up in a hospital who had overdose. They have ways of crystallizing it, like an acid crystallization, to make it more concentrated. And so there's it's called the zombie, the going farming. They're talking about dextromethorphan, right? So try to avoid or decrease that use. The other thing is that it's a lot of drug-to-drug issues. Dextromethorphan plus any of the SSRI or SNRI can give you a serotonin-like syndrome, right? Because of the effects on the serotogenic system. So avoid it if you can. Too many side effects and can make older people be, and as you know, the serotonin syndrome could high fevers, rigidity, hyperreflexia, so not worth it. Oral decongestions, there be marginal effect, if anything. Topical decongestions are effective. You should not use it for more than 3 days because of the rebound effect. Expectorants like guaifenesin is helpful some. You just kind of loosen and thin out the secretions. One thing I don't have here is the Tessalon pearls. Tessalon pearl actually is quite useful. It's a peripheral cough suppressant, and it works on the stretch receptors in the lungs to kind of decrease your cough. I find in my hand, I find it to be quite useful. Then there's all these herbal supplements. We don't have any data for against it. Elderberry, zinc, vitamin C. Don't have a problem. It's not going to, in low doses, not harmful. The other thing about zinc preparation is that zinc lozenges are okay, but never use the zinc intranasal because it actually can cause you to permanently lose your sense of smell. So Zicam, no Zicam. So this is our first pulsar. So a 5-minute stretch. We are at the beach, the waves. This is the Rockaway Beach in Queens, New York. So, enjoy the view. Now I've enjoyed the view. We are going to go on to some questions. Case number 2. Let's see, who's the person that's going to read? Volunteer, or I'm going to pick on you. Raj Grewal. I don't think we've met. Hello, Raj. Can you read for me, please?
Sure. Nice to meet you, Dr. Mensah.
Thank you.
This is a 46-year-old businessman comes in complaining of an upper respiratory tract infection, and you confirm the diagnosis. He is unhappy with being sick. It's a 4th cold he's had since last summer. Past history is notable for hypertension and tobacco use. He is sedentary. Physical examination is notable for findings consistent with an upper respiratory tract infection. The most effective means for prevention of future colds in this individual is, those are frequent hand washing, regular exercise, or smoking cessation.
Let's see what you guys say.
Let's see what you guys said.
Okay, so we have 80%. So let me just share the results.
So 54% said frequent hand washing, and yes, that is the correct answer. Because remember, all of these infections, direct contact to surface, direct contact with somebody who's sick, contact, indirect to contaminated surfaces. So frequent hand washing is your best way of decreasing your risk of getting co-infections. Thank you, guys. So let me move on to the next slide. Okay. So let's see, next person to read, our next reader is Won Jung Ko. Hey, Won, wait, do I know you? I think I know you. You mind reading for me? Dr. Ko? Okay, what about Mohammed Ishraq Khan?
Yes, I'll absolutely read it. A 56-year-old woman is diagnosed with an upper respiratory tract infection. Past history is one of health. She sees you today because her phlegm, previously clear, is now yellow and tan. Which of the following statements is true for this patient? A, antibiotics covering pneumococcus, Haemophilus moraxella is indicated. B, reassurance is the most appropriate management. C, antibiotics prophylaxis to prevent pneumoniasis indicated if she has a fever. D, bacterial infection complicates 1/3 of all upper respiratory infections.
And the answer is?
I will put D. I don't know. I'm not sure about the answer.
Come on, guys. I'm only at 50%. Want to get to at least 70. I don't see who's answering, so.
It's totally anonymous. I don't see anything on my side.
Come on, a couple of more people. Take your pick. Okay, I'm gonna end the poll.
Sorry. You guys got it. You knew it. Okay, that's right. The answer is reassurance is the most appropriate management. This is what? This is a viral infection. The color of the sputum really doesn't tell you much. All it tells you is that you have white cells going to a site of infection. That's it. That's all it is, right? It's just the presence of white cells, and it's not an indicator that it's bacterial, viral, or otherwise. Let's move on to the next one. Next question.
We still see case 3.
I'm sorry?
We see the case 3 still.
Yeah, I'm trying to advance from my end and it's not advancing. Okay, here it is. Oh, I think I had to. Okay, so this I believe is the last one for this series. Jonathan Oxman, did I use you already?
You have not. Nice to meet you.
Okay, sir. Dr. Oxman, would you please read the case for me?
56-year-old woman with hypertension and a pack-a-day smoking history presents with 4 days of rhinitis, nasal congestion, sore throat, cough, and headaches. She requests antibiotics because she developed a real bad pneumonia after her last cold. Which of the following is correct regarding the risk of bacterial complications following URI? So A is significant nasal discharge and chest congestion are predisposing factors for pneumonia, leading to pneumonia in 5% of patients. B, patient with viral upper respiratory tract infections do not develop bacterial complications. Bacterial sinusitis is the most common bacterial complication of URTI, complicating less than 2% of cases. And D, Lemire syndrome is a common complication of URTI and should be suspected in patients with persistently sore throats.
And so let's vote on this quickly. You're doing great so far.
We are 54%.
54%, okay. We need another 20%.
Come on, let's get to 70. Okay. Okay, guys, great. I'm gonna end the
Right.
poll.
So what was the answer? See, you guys are stellar. That's right. Bacterial sinusitis is the most common complication of upper respiratory infections, and it's mixed up only like less than 2%. Okay. Now let's move on to pharyngitis. Pharyngitis is also quite common. 12 million ambulatory visits, making up like 2% of all visits. It's self-limiting, up to 7 days, mostly respiratory viruses. And then the next would be group A strep, and less commonly would be HIV, EBV, syphilis, diphtheria, depending on where you are. As I said, respiratory most common up to 45%. And again, the same players, adeno, rhinovirus, coronavirus, most common. And then nowadays, we have a lot of SARS-CoV-2 causing everything, right? So SARS-CoV-2 will be involved in the pharyngitis as well, influenza. With the group A, strep makes up about 15% and is the most common bacterial etiology. Always remember other causes such as HIV, EBV, GC, and syphilis, to name a few. And in the right setting, diphtheria in people who had not been vaccinated or coming from outside the country and have not been vaccinated, that's another one to consider. Symptoms: sore throats, worsening with swallowing, neck pain, regional adenopathy, fever, headache, malaise, and also all the other upper respiratory symptoms that we've seen before, like sneezing and coughing, sinus discomfort, and also you can get this viral exanthem as well. So group A strep. Generally, as you know, you guys will know, you will get the pharyngeal edema, tonsillar exudate, anterior cervical lymphadenopathy, in addition to fever and the sore throat. You can see in some cases the palatal petechia and the scarlatiform rash, which look like you got sunburn. It's kind of like very tiny red bumps all over you. And then the strawberry tongue, which I really have not seen much of in my own career. Complications of the upper of group A strep. Think of your anatomy when you're talking about this, right? So where does it go? Think about your anatomy. It's going to extend into your sinuses. It's going to go into the CNS, right? The brain, the spinal cord, right? You can get tonsillar abscess. You can get retropharyngeal abscess collection. You can also get, in terms of like extension into the ears. So when you think about anatomy, it makes sense where it goes to in terms of suppurative. Suppurative meaning like bacterial extension beyond the pharynx. And then you have non-suppurative, which is immune mediated. So that's when we talk about acute rheumatic fever, we talk about post-streptococcal glomerulonephritis, and reactive arthritis. EBV, one of the main things it causes is infectious mono, and in infectious mono, 85% of the cases have pharyngitis, they have high fevers, severe fatigue, Rather than anterior adenopathy, they tend to present with posterior cervical adenopathy, very large tonsil to the point that it can compromise their airway. And their symptoms can go on for weeks, some people even months. You can have splenomegaly and atypical lymphocytosis, as well as hepatomegaly in its presentation. Acute HIV. Almost 90% of people with acute HIV are symptomatic. Of those, 40% have pharyngitis. So somebody who comes in pharyngitis in the right setting, think of acute HIV. It could have painful mucocutaneous lesions, these shallow ulcers with well-demarcated white base and erythematous border, no pharyngeal exudate, but diffuse maculopapular rash, can have weight loss, fever, cervical adenopathy, achiness in the joints, in the muscles, and generally present 2 to 4 weeks post-exposure. So always ask about STI risk and exposure to blood products. Gonorrhea and syphilis presenting in pharyngitis. The prevalence of pharyngeal gonorrhea is 15% in men with men. Most of the time it's asymptomatic, but sometimes occasionally somebody might have a sore throat. So you should always ask about oral sex, where are you putting your mouth? And then the secondary syphilis, 50% of those cases present with pharyngitis, and there's an increased prevalence of syphilis in men having sex with men and in HIV positive individuals. In addition to the pharyngitis, they might have like mucosal patches or lesions in the tongue. And they can also have this like the palms and so rash. Normally it presents weeks to months after exposure. Ask about sex and IV drug use. I always put the way I put, oh, sorry. I was trying to get to this. The way I always present it is, I think I went, oh, okay, I asked, to know what kind of sex you're practicing so that I can better assess your risk. And I'm very specific. Oral, are you putting your mouth in somebody's vagina, penis, anus? Insertion, vagina, anus, or both? How many partners do you have? Do you think your partners have other partners? Are you using condom? If so, how often? Are you using any IV drugs and any other drugs like recreational drugs that you might be using? If you're not specific, then you're not going to get the answer. I mean, I just make it like as kind of general and easy as, how are you doing? Talking about sex should not be something like, something that we don't broach. So examination of a patient with pharyngitis, the appearance, the vitals, the HGNT exam. And so we want to make sure that they don't have any signs of obstruction. Do they look toxic? Does the person have a hot potato voice? Is the person drooling because they can't swallow their saliva? Is there stridor? Evidence of respiratory distress, like with tachypnea? Do they have locked jaw? Do they have a stiff face? So it's really important to assess for those. And is the person tripoding so that they can breathe? That maybe the tonsils are so large, or then they are obstructing each other, or maybe there's an abscess further down that's obstructing their airways. So rule out serious complication, which might require urgent evaluation or hospitalization, right? Obstruction from severe pharyngeal inflammation, like I said, extension of the infection into the deep tissues, the peritonsillar, parapharyngeal abscess, infection in the retropharyngeal space. Do they have this suppurative thrombophlebitis, called Lemaire's syndrome? and it's a bacteria invasion that in the neck that caused an infection to the jugular vein with clot and septic emboli. So treatments of pharyngitis: viral, we do supportive. Bacteria, and we think is group A strep. Then we can look at the central criteria. Remember that the central criteria is not sensitive or specific for group A strep. It also picks up group C and group G. It also keeps other bacteria. It's supposed to really be created for like the first 3 days to kind of give you a sense of if there's a bacterial infection going on. You get a point for fever, tonsillar exudates, anterior cervical lymphadenopathy, and no coughing, right? And if it's 0 to 1, no need to do anything else. It's probably viral, leave them alone. 2 to 3 points, then you can do the rapid test. And if the rapid test is positive for group A strep, then you treat for group A strep. If it's for really, people just go ahead and treat, because it's like, if your clinical suspicion is high and the center of criteria is 4, you can go ahead and treat. Some people like to check the rapid as well, but for me, 4 and the proper presentation, you treat. So the rapid antigen test specificity is up to 99%. So if it's positive, then, and in the right clinical setting, go ahead and treat, because of given how high the specificity is. The sensitivity is range 77 to 92. So a negative test might not be a true negative. You might be missing some patients with group A strep. So in that situation, you should consider culture. So who do you culture? Culture people that have risk of complication, like immunocompromised, somebody who's had acute rheumatic fever before. People in college, because there's a higher prevalence of group A strep in that population. People living in areas that have endemic rheumatic fever, right? If you have a very high clinical suspicion and then the rapid test came back negative, you can do a culture. The culture only takes 2 days. One to do is very sensitive and specific. And so you can hold off on antibiotics until you get the results back. And in addition to picking up group A strep, it also group CG, and then also fusiform necrophorium is also picked up. So the supportive treatment is the NSAIDs, analgesic lozenges like the benzocaine lozenges, Halls Max, soothing your throat. Some of them have menthol that also has an anesthetic component. Hot teas with honey is very useful. Ice chips. And humidifier, if you don't have a humidifier, you can just turn the hot water in your bathroom, steam it up and sit in there, and that also is very soothing. If it's group A strep, our antibiotics are Penvk, 500 3 times for 10 days, or cephalexin. If the person is pen allergic, you can do azithro, 500 daily for 5 days, or Clinda, 300 3 times for 10 days. The next palsy. Okay, let's stretch. So now we're somewhere on the mountain watching the sunrise. So enjoy the view. Now, case number 5. Let's see, who can I get to? Case number 5. Okay, case 5. Who can read for me? Victor. Hi, Victor. How are you? Please read for me.
Hello, Dr. Mensah. I'm good. How are you?
I am great. Thank you.
Okay, so case number 5. A 22-year-old woman presents with complaints of 3 days of sore throat and cough. On exam, she is febrile to 38.3 with tender anterior cervical adenopathy. Small white plaques are noted on her tonsils. Appropriate management at this point would be A, empiric treatment with penicillin, B, rapid strep antigen testing, antibiotics only if positive, C, throat culture, penicillin now until resistant pattern is known, and D, empiric treatment with amoxicillin.
So let's vote quickly. Thank you, Victor.
%. Come on, guys, a few more. Okay, I think we have a majority. There's the results.
Okay, great. Yes, the answer is B, rapid strep test, and if positive, treat. Okay, because she has, what does she have? She has the fever 1, she got adenopathy, that's 2, right? I can't see, let me see. And then she has the plaques, that's 3, but she has a cough, so like that's -1. So she really has, like, so she has fever, cervical adenopathy, and she has plaques, right? So she has 3 points. And if you take a point off for even the cough, then it's 2. That's still 2 to 3. So she should have the rapid test, and if positive, then you go ahead and treat her. Okay, so let's do this and then we'll move on. So can we have a reader? Raphael there, Raphael, Dr. Bertassi. Dr. Bertassi, can you read?
Yes,
Thank you.
sure. So case 6, you are evaluating a 32-year-old male who presents for a new patient physical. He describes an illness that he had 3 months ago and was treated in an urgent care center. Blood work was drawn, but he doesn't recall the results. He describes having had a 4-week illness with daily fevers, swollen glands, headache, and myalgias. He had no rash, but his girlfriend thought he looked yellow for a few days. He recalls the doctor at the urgent care center noted his spleen was enlarged. Which of the following is likely to be among his lab results when you obtain his records?
Okay, so let's vote.
We don't see the options.
Oh, sorry, here, sorry.
So letter A, transaminase elevation, atypical lymphocytosis, influenza A viral culture positive. B, HIV antibody negative, HIV viral load positive. C, leukocytosis, normocytic anemia, influenza B viral culture positive. And D, thrombocytopenia, atypical lymphocytes, EBV IgM positive.
And so let's vote on that. How are we coming along?
66%. I'm still waiting to get at least a 70.
We got 50%?
We have 66. So
Oh,
come on,
okay.
guys.
All right, we can make it. Come on, guys.
We have 71%. I'm gonna end the poll and share with you.
And you guys are right. Thank you very much. So in this situation, is the thrombocyte, APV will cause like thrombocytopenia because of the splenomegaly, atypical lymphocytes, and of course the IgM, which is for acute infection, will be positive. There's a lot of overlap with HIV. So if you're thinking HIV could also have the thrombocytopenia and atypical lymphocyte as well. In that situation, you want to make sure that you are testing for the 4th generation antigen antibody for HIV, as well as the viral load. So let's go through rhinosinusitis, which is our last group of infections, and then we'll be all done. So rhinosinusitis, inflammation in the nasal cavity and the paranasal sinuses, mainly viral, and then it could be allergic, or a small percentage of could be bacterial. So again, the symptoms are quite similar to what we've seen before. Remember, this could have a fair amount of facial pressure from the sinus. You can have loss of smell, anosmia, and of course, the rhinorrhea and the headache. So treatment option, given that it's mainly viral, is supportive, 7 to 10 days in terms of the symptom lasting, and supportive care is NSAIDs, Tylenol would do it. Nasal irrigation with sterile saline gives patients a lot of comfort. Avoid tap water irrigation because they've been reported of amoebic encephalitis, so you don't want that. Intranasal help decrease the inflammation and improve the drainage. The intranasal ipratropium, which is an anticholinergic, decrease the rhinorrhea as well. The oral decongestants are also good for decreasing the eustachian tube dysfunction that people feel. Don't use it for more than 5 days because of the fact that, some people who have, history of cardiovascular disease, hypertension, you need to be careful with them because of like elevation of their pressures. With people with glaucoma, specifically angulocosal glaucoma, can have an increase in the pressure in the eyes, and they can cause damage to their the nerves. And of course, people with bladder, neck issues, organs can have obstruction there and be in retention. Intranasal decongestion, that's the Afrin. Great for like 3 days or less because it improves the nasal patency. However, the problem is that if you use it for longer, you can get rebound and actually make the swelling worse, and long-term can damage the nasal mucosa. Antihistamine, great for the drying effects. So that was like viral, that was the rhinosinusitis. Then there's a subset that have a bacterial sinusitis. Even in them, they're essentially still very limited, self-limited. Many will resolve without any antibiotics. They've shown studies where people with bacterial rhinosinusitis, half of them will get better on their own with or without antibiotics in a week. 2/3 will get better with or without in 2 weeks. So the approach has been watchful waiting and supportive care for 7 days, right? If you have good follow-up, you can just tell them, do the supportive care that we've done for the viral infection. And if things get better, leave it alone. If they don't get better, right, or they worsen, then you can give antibiotics. The caveat is that if you do not have good follow-up, and the person has acute bacterial rhinosinusitis, you go ahead and treat. And, bacterial rhinosinusitis is not like culturing, it's just really based on like clinical presentation. So if the person is immunocompromised, go ahead and treat because of the fact that they are higher risk of having complications. Antibiotic options for rhinosinusitis. If the person does not have pneumococcal resistance, then we treat for up to 7 days with either Amox or Augmentin. The Augmentin, adding Augmentin adds extra layer of coverage for ampicillin resistant Haemophilus influenza and Varicella catarrhalis. And because there's been an increase, there's also increased emergence of strep and Haemophilus resistance globally and actually nationally up to 43%. And so adding the clavulanate it's better to use augmentin in my assessment than amoxicillin, just given the resistance pattern that we are seeing. Patients who have risk factors for pneumococcal resistance, then you're gonna do high dose augmentin, that's a 2 gram. So who be considered as at risk for pneumococcal resistance? People who are living in an area that has greater than 10% of pneumococcal resistance. If you're above 65 years of age, you're recently hospitalized within the past 5 days, recent antibiotics within the past month, you are immunocompromised, you have multiple comorbidities, you got diabetes, hypertension, renal disease, you will be at risk. People who have severe infections with high fevers and there's concern for suppurative complication, think about those as also high risk for pneumococcal resistance. Okay, so if the person is pan allergic, penicillin allergic, then you can give them Doxy 100 twice a day. You can do for like about 5 to 7 days. Third generation cephalosporins, if they're able to tolerate, if they have tolerated cephalosporins in the past, and so that would be cefixime or cefodoxime. Or you can also, and then you can add Clender for better beta-lactam resistance to strep pneumo. Lastly, fluoroquinolones like levoflox and moxie, we reserve them for as a last resort because of the fact that they have such high side effect profile. Please don't use macrolides or Bactrim for empiric treatment of possible bacterial rhinosinusitis because of the high strep pneumo resistance. So when do we refer out? We refer out to ENT if you think that there's extension from the sinuses into the CNS, into the orbit, if there's evidence of like extraocular movement, abnormality, mental status, high fever, meningeal signs or irritation. So, and then now we are done with the talk and the take home. I want you to remember that most upper respiratory tract infections are viral in nature. Please don't let your patient talk you into giving them antibiotics because it's not going to help. Supportive care is what you need. With pharyngitis, if you think it's bacterial pharyngitis from group A strep, right, then you want to do your Centaur score. And if it's 2 to 3, do the rapid strep test. And if it's positive, go ahead and treat. With rhinosinusitis, it is really watchful waiting for 7 days if you have good follow-up and give them supportive care at that time. And if they don't have supportive, if they don't have, they can have good follow-up, then go ahead and just treat them. Assess always for airway obstruction and infection involving the deep neck because of the neck is very a small, tight space with very important structures there. Area compromise, your vasculature, closeness, the proximity to the spinal cord. So check and make sure the infection is not deeper. Ask about sexual history and IV drug use to assess all of your patients' risks for STDs. Such as like HIV, gonorrhea, chlamydia, syphilis. And on that, I'm gonna end